Cool. All right, so we're going to talk about CGM use and the importance of it. We all know that CGMs are great here. We've been part of the T&D exchange for about 5 years, and some of our first projects were really pushing that CGM in type 1, and we were so proud of ourselves. We're between 80 and 90% at least of people having CGMs. Now, when you start asking, are you really wearing it? That's a different topic for another day, but at least they have it. However, we really hadn't been paying much attention to our type 2 patients, partly because insurance has been a big issue. Our type 2 patients were like 70-80% Medicaid. And insurance doesn't cover CGMs unless people are on insulin. And even that has been actually something in the last couple of years, where now if a patient is on, depends on a little bit, but like at least on some amount of insulin, some insurances really want two types of insulin, at least on the MAR, in order to cover CGM. And so, but that has shifted in the last year or two. And so we've realized, hey, we can push a little more for these type 2 patients to get on CGMs, but we need to focus on it. So we wanted to work on our barriers in our CGM use and overall increase. And I forgot to add this important detail here: percentage of CGM use for type 2 patients on insulin from 40 to 50%. This is not all type 2 patients. I would be like, hey, we're doing great if that was the case. But I know this is patients on insulin that can qualify based on insurance. And so we started with some initial and then some follow-up questionnaires that we administered to our patients. In one of our nurse practitioners' diabetes clinics, she's our nurse practitioner that sees, she has mostly diabetes clinics and sees quite a large number of our diabetes patients. And she's the one who actually had come to me because she noticed, hey, our type 2 patients are really missing out. So we said, well, let's try to figure out like just what's happening. We have, been working to collect our type 1 data on CGM use, but really we didn't have a lot of baseline data, not really, on our type 2 CGM use. And we're still sort of in some of that process. So we're like, how can we get some information and do something with it before we're fully data mapped, before we have the type 2 map? So let's just start with some questionnaires. So we looked at, for patients on insulin, what we would make note of their A1C, their CGM awareness, and then like their attitudes and different things about CGMs. And so this just shows like the first kind of two rounds of questionnaires. So here's our KDD. And our smart aim initially really was to like identify these barriers and try to increase the CGM use in our type 2 patients. We knew even before starting the questionnaires, just from our work with type 2, like obviously malfunctioning CGMs, access to care, health equity when discussing CGMs, awareness of CGMs, different locations. Like we have 2 different clinics we see patients at. One has diabetes educators, one does not, things like that. So we knew those were things that were going to kind of influence what was going on. And then one important point that also popped up on our fishbone diagram was for our type 2 patients, if they're diagnosed and they don't need to start on multiple daily injections, they're just on Lantus or not on any insulin at all, which more and more, right? We're trying to follow those guidelines and do that for most of our type 2 patients. They don't come to our day 2 education class, which is where we talk about CGM, which I don't think is inappropriate, right? Like they probably don't qualify for CGM. They don't need that day 2 class where we talk a lot about carb counting and all that stuff that goes with multiple daily injections, but they miss out and they don't ever really hear about CGM. And so that became really obvious when we got our first round of survey results back, where the CGM knowledge there on the right side of the screen is for patients with type 2. And almost 40% said they hadn't heard of CGM, which was wild to me. I was like, oh, cool. That's our problem. I was wrong. That wasn't the whole problem, but it was a big part of it. And I think a huge part of that is because we just didn't have it as part of the curriculum, which again, isn't totally inappropriate, but we have to figure out how to make up that gap once they are on insulin. How can we bridge that? All right. And you can see in this nurse practitioner's clinic who was really feeling like there was a huge gap in CGM use. she was right in the sense of that it was the type 2 patients that were really not on CGM. Her type 2 1 patients were doing great though, because I was like, wait, why are her patients doing so much worse? Why our T1D CGM use is pretty good, and we were right. It just was the type 2. It's dragging it down. Um, so asking about like the reasons why people aren't on CGM was very similar across the board. I'll go into a little more detail, but uncomfortable and it comes off easily, either no interest or people put it on and then they like say it's off by 100 points. I don't want it. And so then they don't want to go back once they have a couple, a CGM rare where they're like, no, it's way different than my finger stick that I've been, told to trust above all else is not, it's not going to work. Having lots of like issues, just sensor failures, or insurance. No insurance or insurance wouldn't cover the cost. And that was definitely a huge issue. And so then breaking it down based on type of diabetes, other being like steroid induced or transplant induced, a couple MODI. But you can see for the type 1, the failure and accuracy and malfunction is much higher because they're the ones that are actually wearing it. So then they can have complaints of malfunction. Whereas type 2, it's access and then burnout. But I think really in the type 2, that's actually truly more hesitancy and no interest. They're just not wanting to put it on. They haven't heard about it early on in their education. It hasn't been brought up enough. They don't want to. Um, and so we did like a second round of questionnaires with the same group of people who had been asked the first time. And of our type 1, about 80% report using the CGM most of the time, but really like much less of our type 2 patients reported the same. And really most of the patients that were having trouble getting it were still having trouble getting it the second time. Like if after that first questionnaire, it sparked a conversation and we went ahead and prescribed it. So far in our initial stuff, like the chances of them actually getting the CGM were still really low. Or they were still having issues of it not working in some way. And so the barriers reported were the same, but the percentages are kind of low on this because a lot of our type 2 patients just still weren't on the CGM. The prescription was sent, but it never got to them. And so obviously the awareness and access of CGMs varies hugely. And so working on increasing that, we now have a handout in our clinic. I don't know if patients really look at these, but at least it's something that as providers we can point to a little bit when we're talking about it. And there's some pictures of that we put together ourselves of the CGM on the patient and things like that to help, and what it looks like on the phone and what the device looks like and all that stuff. We've realized that our prescribing, if it has to go through a DME company, we may have been doing that wrong, and that was brought up by our pharmacy tech who helps us with the CGM that we discovered in the last like couple weeks. So that maybe will improve for some of the times where it's like, well, we sent the prescription. Why are you still saying that your pharmacy didn't have it? And then so we need to circle back and keep working on that. And really start thinking about when we are doing education for patients, when we're starting them on insulin, if they're type 2, that we realize we have to escalate care and go to insulin, incorporating CGM in that education time. And so that's going to be some of our next steps. And I did it in 9 minutes.
Time for some questions, if anyone has any.
Hi, I'm Elizabeth from Johns Hopkins. Do you have access to any samples that you could give your type 2 patients?
Yes, we do now. And that's been something, honestly, probably over the summer, we've gotten much better about finding all the ways to get samples. And so that is something, and we have given those out. It has not, and actually this NP, like that was one of the things that she did do. It didn't increase the number of people who we were able to get the insurance though. Like that still gummed us up a lot. Yeah, if people don't know about the Dexcom like hospital discharge thing. David Tooley, he might kill me, but like he can hook you up and it's amazing. And you can get a whole lot of Dexcoms and receivers, which is another big issue because people break receivers and they are $400, I think. Like it's ridiculous. And so patients that like, oh no, I've lost it or I've smashed it. Anyways, now we have receivers we can get out. That's what. Yes, yes. Is that only pediatric? That's or pediatric. Okay, I apologize. Maybe it's only pediatric. I don't know. Okay, okay. No, it's a yes. So it's 3 sensors and a receiver, and you can get lots of extra sensors. It's magic.
Thank you so much for this presentation, Amy Putker, Cincinnati Children's. Curious, and I may have missed this in your presentation when you were assessing barriers. So in our clinic, we're pretty lucky in Ohio. Most of the surrounding state Medicaids will cover CGM, regardless of diagnosis and regardless of therapy. So we're able to get coverage for our type 2 patients. But to be honest, I don't think it's really improved their utilization. And one of the, I think, general themes that come up, at least in our type 2 diabetes pediatric patients, is I really feel like diabetes stigma. They do not want people to see it on their body. I think, I think there's just a lot of factors. So I didn't see that in your barrier assessment. Was that part of it?
It was. I mean,
Okay.
like the hesitancy and the like not wanting to, and I should have gone into that more because that I'm not sure we're asking the right question in our survey to like truly get at that. But that's when I talk to these patients about it, that's definitely what I'm hearing. And it's a good point. And maybe as we kind of rework this, we do have a question about are you wearing your CGM and if not, why? And we have a couple things you can push, and we're working on redoing our like intake form and making sure and probably making that a hard stop. I heard somebody else did that, and I was like, that's a really good idea. But something about like, is it that you don't want to be seen in public or something? I think would be a really good option on the drop down menu because I agree. I think that is a big part of it. And I think the videos people are putting out and stuff, we keep talking about making them, but maybe I should just steal from somebody else. Not right now because our insurances suck in Tennessee.
With these patients and sometimes do a trial or do a sample and let's get 14 days of data, even if they're not going to wear it long term, because I feel like they can still learn from it. Occasionally I can get it covered without insulin, but my other question was going to be, are you doing primarily Dexcom versus Libre? Yeah. Yeah. I have a lot of issues in this population with adhesive. Like I really find that different ethnicities, the skin, it really doesn't stick, and the obesity aspect, and even more so than the type 1 population, I'm just continually troubleshooting how can I get it to stay on these patients, and I wish it was addressed more from the CGMs.
They have they have standardized their education around like making those sensors stick for longer, and then they have also sample kits that I don't know how they occur, those supplies, but they have sample kits that they give to patients, including skin tack and different types of like overlay patches.
Population, I find a lot of those extra adhesives are covered by insurance.
Right.
So then I'm not being like, you can get the cheapest on Amazon.
Yes, they are strictly out of pocket for everybody. I agree. So the only reason why I asked this question is because right now, we're trying to avoid insulin if possible, and we have other things like besides we used to prescribe insulin to everybody. But now that, when you see like an 8% or 9%, you're like, I can do this with metformin and a GLP-1. And those patients still have high blood sugars that require, and they may get worse very fast, as we know. And so being on CGM is, we're lucky. I'm also from Ohio, and we're very lucky to, we have healthy, normal children on CGMs in Ohio. But I think this is a very important consideration.
And I thought your point about just the 14 days of data is helpful and interesting. And I'm curious if anybody has had experience with using, obviously they are not FDA approved and under 18, but some of the over-the-counter options. We've got some families that the burden of dealing with DME is worse than the over-the-counter cost. And I'm curious if anybody has structured either how to do a 2-week, just get some information and have some good education in families in patients who maybe don't have insurance coverage or don't meet criteria for state. Because I think there's it's one thing to say eating a donut makes your sugar go up, and it's another to see that. And I think those of us who give samples to our medical learners, they see that, and I'd love to do that with the patients too.
Public insurance, or even if you have a public primary, even if you have Medicaid secondary, you can get a trial, like you can get a Libre trial for free. So you can just have, like, just go to the Libre, have patients go to the Libre website. Yeah, yeah. I think you actually have to have public insurance. I think it's not a program that's available if you have private. Maybe it's the opposite. Sorry. I think it's private. Yeah, unless it's a secondary and they have private primary, that's what it is. Because then if you just have to verify that you have some kind of private insurance, but then you can at least get a sample, which I know doesn't affect a majority of like this population. So it's still a challenge, but it is a situation where, and I appreciate too, in the state of Wisconsin, we also have like CGM only covered for type 2 patients on insulin. But we are finding more and more that like we still want to recommend it. We still want people to know that it's a great option for them and point out like this is unfortunate and we need better advocacy efforts. And for some people, paying out of pocket for a Libre makes sense for them in their grand scheme of things. Similar to your point of like the DME burden is too great, but I'll just send it to Costco and you could just go buy it.
I don't know how similar other states, but we recently found out in Washington for Seattle, if it's not covered by insurance, each Libre Plus was only $30. I'm like, wow, that's impressive. Yeah, at 15 now. And so we said just maybe buy 1 or 2, right? And then wear it right before the clinic visit, or, have fun for 15 days. But it was so much cheaper than I had imagined.
I kind of almost wonder if intermittent access actually has more behavior change, because when you get a new step number, you walk your 10,000 steps, you wear it all year and you're back to the race on it. But if you do it intermittently, I think there's, yeah, what's not, not, I mean, I think they've shown for MDI, but like, like a type 2 is just on business.
Yeah, just a comment as we're having this conversation. So I actually have a hospital discharge contact with Abbott that I can order similarly trials like I do for Dexcom, and that has been tremendously helpful. And after months, if not maybe a year of leaning into my rep, I actually get readers now for Libre 3 because they kept asking me why is Dexcom being prescribed so much more heavily, and I'm like, it's easy. They made it easy for us. So, and that's really only been a change in the last 4 months. So if you've not been in contact with your reps recently, feel free to, I think her name's Heidi Woods. I'm happy to share out. We threw David's name out there. Well, may as well throw Heidi's out there as well. But I have found that very, very helpful. And I do think that as a company, they seem to be wanting to be a little bit more competitive. So we'll throw that out there.
Right?
Yeah.
And so maybe but if we have to follow after that though, or parents are gonna have to be a barrier for the
Not if it's connecting to the pump, but if they're using it as a standalone system,